Time and we'll start on time. So welcome to this session titled Shaping the Future of Cardiology. My name is Asfar Zaman and these are my conflicts of interest. So what are the session's objectives today? So we know there's been a lot of innovation on the structural heart field, both in the TAVI space and in the mitral and tricuspid space. So we're going to talk about the Myval valve and present to you data to show about the innovation in this area. There's a feeling that innovation in the coronary world has stood still. And what the objective of this session is to show you that this is not the case. We will discover more about the concept of leaving nothing behind with the explosion in the use of drug-coated balloons, with a novel thin strut bioresorbable platform. We'll learn about the relevance of a dedicated bifurcation stent and long tapered stents in complex PCI. You will be aware of the data showing that thin strut and ultra-thin strut drug-eluting stents have better long-term outcomes in terms of target vessel revascularization than the standard 80-micron stents. So we have excellent range of speakers to tell us about all of these innovations in interventional cardiology. To help me achieve these goals, I'm fortunate to have Fadi Sawaya from Beirut as my spokesperson. We have our discussants, Vlasis Ninios, Darren Walters, Stephen Dorman, and Giovanni Esposito. And with that, I'd like to invite our first speaker, Henrik Nissen, to tell us about Myval OCTAPRO. Henrik.
Well, thanks a lot. Thanks you for inviting me here. So I've been given the task on these next few minutes to sort of bring you up to speed with the already pretty impressive clinical data available on this Myval transcatheter heart valve series, despite its still relative novelty in this TAVR field, leading up to a more technical presentation of the current version of the Myval series, named the OCTAPRO. So already there's a lot of data, of course. It's been implanted in more than 44,000 patients, a lot of publications and patient studies, and available throughout the world by now. And it's been used in the most clinical scenarios we know of, the bicuspid and the pure AI and valve, and in the extra large valves, and of course also in mitral and tricuspid positions, and a also relatively good position in the pulmonary valve replacement. So there's a strong clinical evidence by two Lancet papers. The first of them was the landmark study coming out last year, where the valve was randomized towards the best-in-class valves of the SAPIEN and Evolute, 1-to-1. And that was a 30-day primary endpoint with these components you see here. And then we had our own compared TAVI 1 trial, which also randomized, but here we have a primary endpoint up at 1 year with the points of mortality, stroke, and severe moderate organ regurgitation or deterioration. And the landmark trial already came out with a definite meeting the non-inferiority. It had a non-inferiority margin, although of 10.4%, but there was a good distance from the confidence interval, so definitely non-inferiority was proven. In our own study, we had a somewhat tighter non-inferiority margin of only 5.3%, but once again, no chance of crossing that non-inferiority line. So we could conclude also in our studies that it was non-inferior to the SAPIEN series for this composite of death, stroke, and aortic regurgitation or transcatheter heart valve deterioration. And looking at the echo measurements of the effective orifice areas. Also, the data were quite promising. The SAPIEN series had less areas in all valve sizes compared to the Myval. And this is the original data. Might be a little more fair just to push this one over here because the 29 Evolute is only up to 26. But still, when you look up here at the larger valves, there's no doubt that even in these large sizes, it competes nicely with the Evolute series. And we look at our own data when we looked at the CT measured annular area and compared that to the affected orifice area, regardless of the size of the annulus, we had larger effective orifice areas in the Myval series. And also when we looked at the individual valve sizes, it was the same picture. So it does give a definitely nice and larger effective orifice area. So coming to the 3-year data, we have this rather strange inclusion line, and that's because of these patent disputes that we heard of earlier. So we started with this Myval series, and we're implanting 379 valves until we had to stop a little over a year. Then we stopped for a year, and then we included again now with the Myval OCTAPRO series. So what you're going to hear in the 3-year data are only these Myval series. And the patients were a little more male than females. They were mostly in New Hair class 2 and 3, and in the low end of the risk score. But what is important to say that this was an all-comer study, so we did take both acute, subacute, and elective patients, and valve, and bicuspids, everything. And we ended up including 77% of all patients in our region. And the 3-year data came out practically like a mirror of the 1-year data. So there were, once again, proven non-inferiority on all points. And there was an issue in the first year where there was some more aortic regurgitation. Seems to have improved a little bit. I can't explain that because that's just the way the data are. But anyway, the overall result is definitely non-inferiority. Looking at death, same curves. Looking at stroke, same curves. So just to stop there, here the 3-year data definitely just demonstrate that this valve used in the largest one-to-one comparison of any 2 transcatheter heart valves to date, and used in a very large number of all-comers, so that we can really generalize them to our daily clinical practice. It still showed that the good 1-year data seems to continue up until 3 years for now. And we will continue, of course, to follow them up to 10 years. So coming more to the technicalities of the Myval transcatheter heart valve series, we started with the original Myval from whom you just saw the data. Then we went over to the OCTACOR, and for now we're at the Myval OCTAPRO version. And the OCTAPRO version has, of course, a lot of technical features written here, but for me, one of the most important is the fact that it only foreshortens 10 to 12% when you use it. Of course, it had all the other nice features with the external internal skirt and a proprietary treatment with anti-calcification and a strong radial strength with that cobalt alloy frame. But as we already know, it also has these features of using all these intermediate sizes and have the additional large sizes, which really allows us to tailor the chosen valve to the individual patient. It also has some nice features regarding foreshortening. So these are just our benchmark data, but this is just to show that if you use the standard balloon and you crimp it and then you inflate it, then you will only have like approximately 3 millimeters in the LVOT when you use the planned markers of the valve. And the planned marker of the valve is this marker sitting here, which you want to have at the level of the annulus. And then there's these unique stoppers which allow you to crimp the valve on the balloon outside the patient. And these stabilizes the valve so it won't slip away. Once crimped on the system, it looks like this. And what is very, very nice is that it's easy to retrieve the crimped valve even after having been into the patient, which gives you some confidence. If you want to try to avoid predilating too much, there are maybe some borderline cases where you're more inclined to just let it try here because you can always take it out and post-dilate. And that sort of gives you some confidence as an operator. It comes in all these sizes, and the personal experience is that with the current crimpers, which are not from the company and they are working, if it's not ready, a new crimper, but the current crimpers are really hard to push when you get up to the last sizes. So you need to do some practice, but otherwise it works, and the shaft is ergonomic and you can flex it like you can with the other system. So it's a nice system here. And they have their own Python sheet, which is an expandable sheet, and it's the same sheet used for all sizes. And the positive thing with the new OCTAPRO Pro version is that it's actually easier pushable than the Octa Core version was. So it goes in quite smoothly. The crimp bores looks like something you've seen before, except that it has these dials, which is unique. And the reason why it has this is because you can actually try to align the valve to the coronaries. So what you do is you get your standard CT orthogonal view, where you find out where your right coronary departs. And you use it for, when you put it into the crimper, you actually do the complete opposite. You put the valve in the worst position, looking at the CT scan. But what happens is once you get into the patient, what is superior here, it becomes anterior. And as it moves around, it sort of flips around so that you get the valve in the intended position so that the coronaries actually come in where you want them to come in. Of course, this is the ideal case. It's never like that in all cases. And we are in the in the Compare series, we are doing CT, so we will have the largest data on if this really works. We don't have them yet, but they're coming. I'll just switch this one. This just to show that if you have another angle, of course, you crimp it in another way. But as an operator, this is a really nice feature. This line just shows where the annular level is, so that's where you want to end the valve. So if you put the slower marker, this one, at the annular level, and then say this is what you want to put it and inflate it, what you see in this picture is that there's barely any foreshortening. It is something between 10 to 12% in the largest one, but your eye practically can't see it. So it's a very, very precise and confident position of the valve, and giving a nice, usually 90 to 10% implant. And from the company, of course, there are much more data out there, but the company has some data on 30 patients here where they try to see patient prosthesis mismatch with this valve. And as you see, these are the small valves, but even if you look at the BSA, which are not all small people, you have no cases of patient prosthesis mismatch, and of course not when you're going to the larger sizes. So it really gives you confidence that you're able to put in a valve which will probably suit the most patients. So the transcatheter heart valve series of Myval has shown that it has hemodynamic results and at least are comparable to the current market leaders. It has this extended portfolio of valves which will allow more precise tailoring in an individual patient to his or her anatomy. And particularly for us in the Nordics, we are happy to have these large sizes because those patients come once in a while where we really need the extra large sizes. It's simplified by you crimping directly on the balloon and putting it in, so it's very quick to put in the valve. And it gives you this confidence for a second chance since you're able to put it out, and of course not after you inflated it, but before you inflated it, to do some redo maneuvers. And the very little foreshortening gives you a very good chance of really obtaining the intended implantation height during the procedure. And potentially, time will tell, increase the access to the coronaries using this octa-line technique. So, thank you very much.
Thanks, Henrik, for that overview and personal experience. There are microphones dotted around the alleyways. Please feel free to ask questions. Darren, I'm going to come to you first if you have any questions of Henrik on the presentation on the OCTAPRO.
Yeah, Henrik, that's an impressive presentation. I mean, we've been nearly 2 decades developing and implanting TAVI valves, and this is the first series of studies to show a new technology that's equivalent to the existing 2 platforms. So I think it's a very exciting time, and I think it's a disruptive innovation, this new OCTAPRO or the Myval system. One of the impressive features is this incredible range of sizes, which cover from small annuli to very large annuli. And you don't seem to be in the position where you're trying to underfill, overfill, caught between size ranges. And that seems like a simple innovation, but that can mean a lot for how you deploy the valve, the expansion of the valve, and a whole lot of potential benefits in terms of durability, depth of implant. Can I draw you out a bit more on the size range and how you find that in clinical practice, how that...
Yeah, I mean, we probably all have we do have those borderline cases when you only have the standard sizes, where you're sort of inclined to, should I overfill, should I underfill, where you have these pros and cons. And that's basically taken out of the equation now, because you always have a valve where you're not worried about putting that in. If that has anything to do with durability for the competitors, of course we don't know, because we all have been doing that for a long time, over and underfilling. But from a technical point of view, I mean, the valve are developed for a certain size, so you would imagine that it matters to longevity, but time will tell, of course.
Great, thank you. In the interest of time, I'm going to ask Holger, please, to come up to the podium and discuss his presentation.
Dear colleagues, thanks for having me. I'm present to you the newest technologies on BRS and DCB. Well, as we all know, we have problems of the current PCI tools. If you look, although we have this progression in technologies regarding the DS, they are related to adverse events, continue to accrue after the first years, and have an annual event rate of 2 to 3% a year, with no differences between the second and the first generation. And also, although promising, the leave nothing behind concepts of bioresorbable scaffold failed to improve the short and long-term outcome compared with the drug-eluting stents. This was driven by poor acute performance and loss of long-term vessel dynamic support following scaffold resorption. And finally, the drug coating technologies have shown inferior performance to DS in native large vessel, and that's the reason why we all think that we have to share with you newest technologies on the concept of leave nothing behind. And there are clear advantages or benefits. So first, there's no chronic inflammation, the scaffolds dissolves, there's a reduced long-term immune response, and we have no permanently caged vessel, so that the vessel regains natural and structure and flexibility, and we have this restored vessel motion, which means that normal vessel movement returns after the resorption. Nevertheless, the BRS failed to improve, and this comes with a dismantling, with a collapse of the polymer structure, and we had also the problem with the thickness of struts, which was 150 microns in the former iterations. So the question is, can we do better? And we have, of course, a portfolio on bioresorbable scaffolds, also now with the Myval 100. And the first benefit you can clearly see is the strut thickness of 100 microns, which comes to the commercially available DS. The technical feature of the Myval 100 contains a PLA backbone. There is a closed cell design in both ends and the open cell in the middle part. That brings us providing a high vessel conformability, and there is the drug coating with sirolimus of 1.25 micrograms per square millimeters, and so we have a higher radial strength, although we have this 100 microns of strut thickness, so we can see that the radial strength retain and is comparable to commercial available DS. So there are also couples of triaxial platinum markers at both ends of the scaffold, which enhance the visibility and gives, of course, a sense of virtual tubing, which ensures successful implantation of the scaffold. The absorption process comes with an degradation and with an hydrolysis of the PLA polymer backbone, gradually absorb the material to lactate acid. And for the first 3 to 6 months in the vascular healing phase, so you have retained and maintained stability. After that, the Maris 100 lose its strength, of course, and there's a fully bioresorption after 3 years. So this is a typical case where we treat a 59-year-old male patient with typical angina, LDL of 156 milligrams per deciliter, and a smoking history. So we can see this high significant lesion on the LAD in the RO cranial view. Also in the LAO cranial view, you can see the mid part lesion in the LAD. If you look at the OCT, you can appreciate that it's a lipid-containing plaque morphology without calcification, with a diameter of roughly 3.5 millimeters in the proximal part and the distal part, with an MLA of 2.5 square millimeters. So we performed a BDIL with an NC balloon 3.0, and we implant a Maris 100 of 3.5 over 24 millimeters length, post-dilatation with a 3.75 10 millimeter balloon, and this is the final angio. Well, regarding the implantation process, we have to keep in mind that there is a specific deployment technique. So under fluoroscopic guidance, you have to slow inflate the scaffold at the rate of 10 seconds per atmosphere, up to 4 atmospheres. And you have to keep in mind that the pressure drops from 4 to 3 as the scaffolds self-unwinds. Then you have to wait for 30 seconds, and after this waiting phase, you can start the inflation, and you can continue to inflate at the rate of 5 seconds per atmosphere to nominal pressure. This is very important. Otherwise, you have the problem or the danger that maybe the polymer can rupture. There are expansion limits of the Maris 100, which are comparable to the expansion limits of former iterations. So you have to know that you should keep into the limits of 0.5 millimeters, so that you can, of course, expand a 3.5 millimeter up to 4.25, but it's recommended to stay within the 0.5 millimeter range. So coming to the patient again, this is the OCT post-implantation, and you can see there's a good expansion, a good apposition of the scaffold, and gained lumen in this patient. Looking at the data, so we just have last year presented the 3-year data of roughly 100 patients, showing a good MACE rate of 1.87%, no cardiac death, no myocardial infarction, and there was also no scaffold thrombosis. The second tool for the concept of leave nothing behind are the DCBs, and we have witnessed of euphoria of these DCBs. However, we have robust data of these tools showing that there is a similar rate of events in the most lesions. However, not for the large native vessels. There are no randomized controlled trials data so far available. However, all these trials was done with paclitaxel-eluted DCBs. So this gives place and a space for the mosaic as sirolimus-eluted DCB, which comes with a novel drug delivery and with a unique formulation containing solid lipid substrates consisting of sirolimus. This is a rapid release of drug into the tissue, which allows to come to every layer of the vessels with the drug. So this is a case-based experience here with an instant restenosis in the distal right as you may appreciate, if you look at the OCT, you can see that there is part of hyper proliferation of the intima as well as neoatherosclerosis and the stents which were implanted 3 years ago. And so we did a Bredel with an NC balloon and a Bredel with a cutting balloon and performed then a treatment with a sirolimus-coated balloon of 20 millimeters for 45 seconds. So if you look after the treatment in the OCT, you can see a nice result showing regained lumen and a good flow in this vessel. There are only limited data so far coming from a clinical registry with a follow-up of 24 months showing low event rates, as you can see here. And if you compare this with former studies, the event rate is even lower in these small patient-based registry. So to conclude, despite advancement, the current DS still have long-term limitation with adverse events of 2 to 3% per year. The bioresorbable scaffold have so far failed to deliver superiority. DCB have likely underperformed in native coronary arteries, especially in larger vessels. And the concept of leaving nothing behind remains appealing to the potential benefits like restored vasomotion and reduced chronic inflammation. And novel devices such as Maris 100 or the DCB with sirolimus-coated may overcome these former limitations. However, future clinical trials are essential. Thank you very much for.
Thank you, Holger, for that excellent presentation. In the interest of time, I'm going to ask Stephen just for a quick comment or question on that presentation.
Thanks very much, Holger. I think we all buy into the concept. It's really exciting to see development in the space. I guess many of us can remember the Absorb trial and our enthusiasm. And I guess the question is, what is different this time? Is it the strut thickness? Is it that we're going to be putting them in different people? Is it the substrate? Why do we have more optimism on this occasion?
Well, of course, it's the strut thickness. As we all know, the strut thickness was one of the major problems bringing us to the scaffold thrombosis just in the early phase after implantation. And it's, of course, the radial strength which is improved, obviously, with the newest iteration of the bioresorbable scaffold and the PLA. Material still is promising and has comparable radial strength to the commercial available DS.
Great. Thanks, Holger. Thank you. Antonio, could we ask you to come out on stage, please? So Antonio is going to tell us about the next-gen complex PCI toolkit.
Okay, as you know, for many years, stepwise provisional stenting has been the preferred strategy for coronary bifurcation lesions because a two-stent approach has been associated with inferior outcomes. Whether this approach applies to all two-stent techniques, especially for truly complex bifurcation lesion, I believe is still controversial. In the era of newer generation DES, accumulating data support a planned two-stent strategy, especially when the decay crash or even the culotte technique is used, that show to be superior in comparison to provisional stenting for complex bifurcation lesion with a significant reduction in MACE, TVMI, and TVR. When a two-stent approach is needed, in my view, well, for true bifurcation lesion, both the main vessel and the side branch have a significant stenosis. Medina 111, of course, 101, but even 011. The branch should be large with a large distribution, what I call a side branch that you don't want to lose during the procedure, with diffuse disease that extends above 3 millimeter, side branch with an acute angle, with a higher risk of carina shift, and when you expect difficulty in side branch rewiring, especially in retroverse origin or side branch dissection. We should not forget that in patients randomized to a stepwise provisional approach, a second stent was needed in 16% of those enrolled in the EBC2 trial and in 22% in those enrolled in the EBC main trial. And this issue is addressed by this device, a bio-main branch sirolimus-coated coronary side branch stent. The stent is divided in 3 segments: the main branch anchoring segment, the flexi-connector segment for side branch continuous access and protection, and the distal taper segment. This is very important because the stent is mounted on a tapered balloon. It's coated with sirolimus and has 4 markers, proximal markers and distal markers. But the most important markers are the central markers through which you can really position the device at the carina. Look at the metrics. We have different stent length, but especially we have different length of the main branch anchoring segment and the distal segment that goes in the branch, so we can treat long lesions. This is the implantation techniques. It's mainly a culotte technique. Of course, you have to prepare the lesion. All the bifurcation lesions should be prepared very well, maybe if you have calcium with IVL. And the device is implanted precisely at the carina. Then you post-dilate the device with a non-compliant balloon. And then the branch wire is withdrawn and is advanced in the main vessel. You see that the main vessel wire is jailed, so you can take out the main vessel wire before implanting a workhorse drug-eluting stent. Of course, it's very important to do a final kissing balloon to achieve a perfect apposition of the device and have a pristine result, a very good apposition of the struts. This is the first study that we ran. It's the first clinical study with this device, has been published recently. We treated a small number of patients, 58 patients. You see the true bifurcation lesion, all of them Medina 111, mainly stable angina, the LAD diagonal branch in most of the cases. And you see here that we achieve 100% procedural success. In all cases, it was possible to perform final kissing balloon. A standalone rise in high sensitive troponin above the 99th percentile was observed in 6.8%. And please note the good result by QCA in terms of diameter stenosis after the procedure in the main vessel and the side branch. At 18 months, we observed only 1 case of spontaneous MI that eventually occurred 2 days after PCA, but this was due to the main vessel stent, a resolute. A sudden death at 11 months that we consider has a late stent thrombosis, but was not defined, and no other adverse clinical event. Let me show you a representative case. This case was studied with CT scan on the image A. You see that radiography demonstrated the Medina 111. And please note the precise positioning through the markers, the 2 markers, the 2 central markers at the carina. This is very important to position exactly here the device. Here you see the results after the branch, the bio-main branch treatment, and then the workhorse is applied and the final result. And this is a very nice view of the final result is what we call the figure of 8, because you see the branch and you see the main vessel with perfect apposition of the device. So why I like this device? Because it's not technical demanding compared to all the other techniques that are used for bifurcation lesion. It's not time consuming and is not operator dependent. The device is very deliverable and has a very nice matrix that can cover all the anatomies. The design conforms to the lumen geometry, provides side branch permanent access. You don't lose a branch, this is very important, and reduce the risk of stenosis. It's not contingent on anatomic variation, lesion complexity, without bifurcation angle limitation. And as I said, the landing zone has a generous tolerance, so you can be very precise. It's single wide tracking, so no risk of bias and no need for rotational orientation, and decrease multiple layering of stent struts at the main branch and the carina site, potentially reducing the stent thrombosis risk. I believe that all these features improve the procedural success and the clinical outcome. And let me now shift to the challenges of very long lesion treatment. They pose unique challenges to us, and they're associated with higher risk of ISR and adverse clinical events. Until now, stents of length more than 48 millimeter have not been commercially available, forcing the use of multiple overlapping DS in more than 10% of patients undergoing PCI. And we know that overlapping stents are associated with increased inflammation. You see an image from a porcine model down here, and delay healing that may increase thrombosis risk at the overlapped zone. In addition, ultra-long lesions are often located in the LAD that has many side branches, which may be jailed at the overlapped zone and typically tapers from proximal to the distal segment. Which are the potential benefits of using a single stent instead of multiple overlapping stents for very long lesions? Well, of course, you avoid metal overlap, but even more importantly, you reduce the risk of geographic miss. You see here a gap left after overlapping stent. These were not overlap, of course, and you see what happened at 6 months. Lower clinical events raised, so less fluoroscopy time, less contrast used, and also reduced procedural cost. This data come from the SIRTAX trial, over 1,000 patients. Of them, 134 were treated with overlap DS, and as you can see in the diagram, the overlap patients had a higher binary stenosis, higher lay loss, higher risk of adverse cardiac events, including death and MI. There is another point to make with this kind of lesions. They taper, and this is a problem for matching the proximal segment. If you have a stent matched to the proximal segment, this may result in overdilation to the distal segment, increases the risk of dissection. Stent matched to the distal segment may result in underdilation of the proximal segment, leaving an opposed stent with significant residual stenosis. Theoretically, taper stents ensure better matching between balloon stent and coronary vessel. This is exactly what BioMine Morph sirolimus-coated tapered coronary stent system is addressing. This stent has different lengths, 30, 40, 50, 60 millimeter in length, is sirolimus-coated, is clamped on a rapid exchange balloon with short shoulders to reduce the risk of dissection. But please note that the proximal segment has different sizes, 3.5, 3.0, 2.75. The distal segment, 3.0, 2.75, 2.50, 2.25, to match all the anatomies that you can find. Another good point is the hybrid cell design. This allows excellent radial strength and high flexibility, and morphology-mediated expansion at the center of the stent, reducing even more the risk of edge dissection. These are data from one of the first experience with a BioMine Morph 60 millimeter long tapered CS in different clinical scenarios, and you see the pristine result that can be achieved with just one stent in these very long lesions. These are the clinical registry data in over 1,800 patients. You see the number of lesions. You see that the main location was the LAD. You see the stent length, the quite high successful outcome, acute successful outcome, and the quite low risk of major adverse cardiac events at follow-up. So in conclusion, I believe the BioMine Morph sirolimus-coated tapered coronary stent system has the potential to improve the treatment of long, very long, and diffuse lesions in branching tapered coronary arteries because it conforms to natural vessel tapering without altering vessel anatomy, avoids overlapping and geographic miss, problems that may increase thrombosis and restenosis risk, decreases procedural time, radiation exposure, and even constant dose. And at the end of the day, it saves money, less cost than multiple overlapping stent use. Thank you for your attention.
Thank you, Antonio. If I could ask Evald, please, in the interest of time, to come and exchange places. Vlasis, any comments whilst the next
Just a
speaker is
quick
coming
question, really. I mean, it's very
Thank you.
exciting news with the bifurcation stenting. Do you see that changing our practice? Because we've all been trained to have a provisional stenting approach for the side branch. Do you think that will change with this approach?
Well, I think that for real complex bifurcation lesions, the data from the DK crash are showing that two stents in specifically complex lesion is better than provisional. And I alluded to these anatomies in the first slide. There are cases in which you have to use two stents up front.
Yeah.
And don't forget that if you lose a major diagonal branch or a major marginal branch, you have a quite large infarct. And this stent allows you to fix the branch, and so you can do your job on the main branch with safety.
Thanks, Antonio. Very comprehensive answer. Evald, if we could ask you to, we're short of time, so if we could ask you to go through your presentation, please. Thank you.
Thank you very much for the kind invitation. I think I can go through this quite quickly so we can catch up some time talking about the SORT OUT XII trial. So we have the evolution of the DES. We come from first generation to second generation, third with biodegradable polymer, and now the fourth generation, the Evermind 50. And it's interesting because ultra-thin stents, less than 70 micron, are superior to thin strut stents in this meta-analysis. The target lesion failure rate is significantly reduced with this. Again, we have this closed cell design in the ends. It's around 25% split into the proximal and the distal end, and the middle of the stent is open cell. We call this the hybrid stent design. We have them in very many different diameters and length. And this is how it looks like, the closed cell here versus the open cell. The nice thing is it's very easy to wire a side branch through these stents. You have nearly 1 millimeter, and it's easy to pass most of conventional balloons because crossing profile is less than 1 millimeter. This is also our experience in the SORT OUT trial. The closed cells, when you try to dilate them, this is the maximum you can dilate them. You can get to 3.2. And it has implications. We try to avoid having the closed cells crossing significant big vessels. We don't put that across the circ because this opening will not be aligned towards the circ. And certainly we don't want to have overlap crossing. It has also implications for the DK cross, as we have discussed before, because we don't want to have the crushed part in the side branch, because then you have two circular parts of the stent, and we have had 1 or 2 cases where we had some difficulty in getting in after DK cross, so we have changed the strategy. We put more stent into the main vessel before we cross when we do this stenting. Very useful information for you. They are maintaining the radial strength because they become wider in the middle part. The closed cell in the ends make them suitable also for ostial stenting, and the open cells, because they become wider, you maintain the radial strength. They are easier to get in, that tracks the coronaries very nicely. And the polymer do not crack when we dilate them. So the dilution of the drug is very much maintained, even though you dilate them and post-dilate them. We are doing the SORT OUT trials. We've done that for 25 years. We are covering 3.2 million people, and we are now come to SORT OUT XII, where we are comparing the everolimus eluting stents, the biomime with the science stent. We take 3,150 patients 1-to-1, and the primary endpoint is target lesion failure at 1 year, cardiac death, myocardial infarction, and TLR. Very conventional endpoints. We have reached 913 patients. We think we will finalize the inclusion in 12 to 15 months, and then we have 1 year to wait for the primary endpoint. We take nearly all the patients. It's really a true all-comer trial. We also look at the depth. We try to look into what happens if we take away aspirin after 1 month and keep them on prasugrel for 11 months and then back to aspirin. It's a superiority trial for reducing major bleeding. That's the primary endpoint. Safety endpoint, will the patient get myocardial infarction? So it's powered both for superiority and for safety. It's a little more difficult to include patients. We have reached 91 patients at the moment. So I would like to take some questions for you. I think we are back on time.
Thanks.
We have 1 minute.
I really appreciate it. Giovanni, one comment, question of Evald before we have the wrap-up from Fadi?
Yes, I just want to ask you whether we have now you show that also the radial force is not inferior to some other platform, but since now we have also the bulking system that works very well, do you think that the future will be only using ultra-thin stents instead of other platform?
Yes, if SORT OUT XII shows it's non-inferior or maybe even a trend to superiority, I think that this is the way we go, and the meta-analysis suggested that this is the way it's going, if we are not going for leaving nothing behind in the future.
Yeah, no, I agree. Thanks, Evald. Thank you very much for keeping on time. We're going to have the wrap-up now of the session from Dr. Fadi Sawaya. Thanks, Fadi.
Yeah, I think this was a very nice session, and just we want some key takeaways. So we went from the structural field where we talk about the OCTAPRO, and the OCTAPRO really has redefined some of the best of the balloon expandable with the very minimal foreshortening, which I think this is a very important, where you have predictable deployment. And then we move to the concept of leaving nothing. So BRS is back in the game. And with the MIRES system, hopefully this will, with the 100 micron thickness, this should be also a game changer. And you know, we've moved a lot to DCBs, and we need more data on this, but I think the word of DCB has exploded, and hopefully we'll get more data compared to drug-eluting stent. And for the tapered morph, tapered coronary stent, I think it's a very nice system. You have long stent and tapered. When you have a distal vessel of 2.5 and a proximal of 3.5, these are really nice systems, so you don't have distal edge dissection. And I think also from what you showed about the ultra-thin Evermind 50, this also, I think, the platform for the future, the same as the Orthero showed that there's small stent strut has some advantages, and I think this will be showed in the SORT OUT XII trial. And thank you for all your attendance in this meeting.
Thank you, everybody.